Any closing comments on the area of, we'll just make it broad for the last section, for triple negative in terms of future directions, or good pearls that we have for our listeners in terms of clinical management? I'll just go around the arc here, starting with you, Adam.
I mean, it's great that we're now talking about third line triple negative breast cancer and how to manage it. I mean, clearly you even have to go to the earlier lines, but you know, it clearly is the entity where we don't have as much. And I think that we're getting there. I think over the next couple of years we'll have more things. I think AKT inhibitors are probably going to be have some role, and I think immunotherapy will have a role in selected patients. PARP inhibitors, how we use them, will have a role. I think that those are three things we never had. I think that we now have.
Yeah, I think the encouraged by immunotherapy, by adding checkpoint inhibitors to chemotherapy in the curative setting. We have to wait and see, you know, there's more data, but hopefully event-free survival will hit on 522. It'll become a rapid standard of care. And I think, you know, the ADCs, the other big story is the ADCs, you know, increasing the therapeutic, you know, benefit for our patients. And sacituzumab hopefully will be coming along soon.
Yeah, I think, I mean, I would say it's hard to add a lot to the idea that we're making big advances in various agents, but I think the ADCs are, to me, an exciting new area of investigation, and immunotherapy combinations, which I think are going to be really important for us in terms of taking the, you know, there's the small subset of patients who benefit, and then there's the larger group of patients where we really need to figure out better combinations. But I think what's really critical for us is moving these relatively rapidly into early stage disease without hurting our patients, and this is a balance.
Yeah, no, I mean, I don't have much else to add. I mean, I think clearly the ADCs, but you know, one of the interesting things is that the ADCs look like not only are they going to be good for HER2-positive disease and triple-negative disease, but these HER2-low cancers, which is a huge subset of ER-positive, but also triple-negative cancers. I think that there's already great potential right there. Plus, I think we have clear proof of concept that if you have a good target, we now have very good payloads, that this is an area that's going to continue to grow. But I think of all the things that we've talked about, to me, I agree with Joyce that if we have a drug that in the triple-negative early disease setting that improves event-free survival, like we hope the Pembro study will show, will bear out. I mean, that's such a game changer and what we've been looking for a very long time. So, fingers crossed.
Well, thank you all for your insights and comments. I think this has really been a very important and groundbreaking meeting. So it's nice. I hope we have more annual meetings of this magnitude. Before we end discussion, I'd like to open up the floor for any last-minute comments. We talked about triple-negative, but now if we just look at all of the sections we covered, hormone receptor-positive, HER2-negative, what are your thoughts on the key advances, particularly as they apply to our practice, to patients being taken care of by our listeners here? Let's start on this side and go around this time.
Well, I think, for this particular meeting at San Antonio, I think having 2 and potentially 3 new drugs for late-stage HER2-positive metastatic disease is really going to be impactful. As we talked about, there's going to be some room to figure out exactly how to, manage these different drugs, but I think it's a clear win for patients.
And I think, we've learned now that we should be giving hormone therapy, and I think CDK4/6 inhibitors as first-line therapy. We have a lot of excitement based on even the data we saw at this meeting about moving these drugs earlier in the course of therapy, and they're being combined in HER2-positive disease as well. So it's kind of exciting that we now, at this meeting, now have 2 classes of targeted agents, oral, that have minimal toxicity. We have tucatinib, which seems to be well tolerated, this whole class of CDK4/6 inhibitors.
I guess again, on the theme of moving really important agents, in this case, survival with tucatinib quickly, is really wonderful. I was so happy to hear that the adjuvant trial, it's with TDM1 in a Catherine-like approach, is going to be starting while the metastatic trial of TDM1 plus minus tucatinib is going on. Hats off. That's great. Why wait? So that's what we really need. And so I think that's, getting these things as quickly as possible into the early stage is the way to go.
Yeah, it's just rare to have so many advances, I think, really groundbreaking advances in a tumor like breast cancer in 1 year. I mean, 2019 has been a pretty good year, I think. as we end this year. And the issue is that, again, when you always say to San Antonio, what am I going to do tomorrow? Obviously, we're not going to change anything for tomorrow. I mean, these things need to be approved, but I think 2020 is where all of these will suddenly have an impact. I think it's very true.
Well, thank you all so much for your contributions to this animated discussion. On behalf of our panel, we thank you for joining us. We hope you found this peer exchange discussion to be useful and informative, and we hope that you tune in for other such educational events. Thank you.